Chapter 51 is about kind of putting all of this information together and how do we use antimicrobial agents effectively in treating patients. So the general approach to treating a patient with infection involves taking cultures, then treating symptomatically based on the most likely diagnosis, and then getting results back and targeting therapy based on those results. This is the usual pathway of the treatment of patients with infections. You typically are going to want to get cultures before you introduce any antibacterial agents into a patient's treatment, because once you introduce those agents, you are more likely to cause some of those cultures to be falsely negative. So you'll kind of conceal any infection. So the choice of antimicrobials is typically based on, obviously, what is your most likely diagnosis, what comorbid conditions the patient has, renal failure, liver dysfunction, etc. That would affect your kind of side effect profile that you're looking for. Obviously, allergies, and then immune status comes into play because patients who are immunocompromised for any reason, you typically are going to want them to be more aggressive in your choice of antimicrobials than you are with someone who would be expected to have a more stronger immune system and be able to offer more of a fight against whatever given infection. So culture results are obviously very important in the treatment of patients, but they are also fraught with some limitations, and this slide just summarizes those. When you get, for example, a sputum sample, obviously a sputum sample is intended to be from the lower respiratory tract, but can be easily tainted with saliva and mouth flora. So that's something that's not uncommon. When you do a blood draw for to culture blood, your specimen can be contaminated by surface bacteria when the needle made the puncture through the skin. If there was not ideal cleaning of the skin surface prior to getting a blood sample, then you can get skin flora in contaminating your blood culture and leading to false positive results. So it's important to look at the results in the context of what's happening with the patient, etc. There are some bacteria that take a long time to grow. Probably one of the more common is mycobacteria. It's not only necessarily a long time to grow, but requires special culture medium to grow. So this can be challenging and lead to false negative cultures. We talked about this earlier in the class that antibacterial agents are essentially come in two fashions, bacteriostatic and bactericidal. Bacteriostatic drugs only interfere with replicating some sort of the replication process, and they do not absolutely inhibit bacterial replication. Bactericidal drugs typically are things that affect the cell wall, so they cause it to not to be synthesized, etc. And bactericidal agents, are considered preferred when you're managing acute infections or infections in locations where the consequences of not treating the infection fully would be devastating. So that is patients with brain infections, meningitis, or encephalitis, patients with infections in hardware, coronary valves. These are areas where the more serious the infection, the more likely you're going to want to choose a bactericidal versus a bacteriostatic drug. And this is just a list of the bactericidals and bacteriostatic agents, and this kind of covers um, drugs from a number of the different chapters we have reviewed. In other lectures, we've had a few examples of drugs which are said to act synergistically, meaning that the combination of the two drugs works better than either drug alone. And I mentioned that the classic example of this is trimethoprim sulfamethoxazole, which is Bactrim, and both of these are antifolate drugs that act in sequential steps in the production of folate, and they work more effectively together and therefore are usually used in combination. Other examples of synergism, penicillins and aminoglycosides. Penicillins inhibit the cell wall, and aminoglycosides act within the cell. So if the cell is already impaired, it makes it easier for the aminoglycosides to get into the cell to do what they need to do. So that's another example of synergism. And then ampicillin and sulbactam. We mentioned that some bacteria have developed enzymes that make them resistant to certain of the penicillins, and sulbactam is used to block that enzyme, so that ampicillin can be more effective. On the other hand, there are some combinations where the use of two drugs in combination is actually less effective than their use together. And an example of this is often the use of a bactericidal drug with a bacteriostatic drug. Because a bacteriostatic drug, it can essentially slows down reproduction of the bacteria. But bactericidal drugs like to act on on bacteria that are rapidly reproducing. So to the extent that the bacteriostatic drug slows down the replication of the bacteria, it makes the bactericidal drug less. I want to just make you familiar with this wound classification criteria that is used by surgeons to essentially estimate the risk of postoperative infection based on what's happening in their surgery. This divides divides in surgical wounds into 4 categories: clean, contaminated, contaminated, and dirty. So the clean is a procedure in which there's going to be no entering of any orifice, and you're mostly working on the skin or some superficial procedure, and there's no evidence of skin breakdown or any infection. Clean contaminated is going to be things where you're going to enter an orifice, but there's no obvious breach in technique that would cause you to think that there's any spillage out of that organ, like maybe a bronchoscopy. Contaminated is when you are dealing with spillage from an orifice, and so obviously there is the potential for some infection or a trauma, like a penetrating trauma, like a splenic laceration, which is fairly new. And then there's dirty, where there is gross contamination and infection present, such as like a ruptured appendix. And you can see that the rate of postoperative infection goes from a low of under 2% in clean cases to higher than 40% in dirty cases. So when do we use surgical antimicrobial prophylaxis? Some of this is based on surgeon preference. In general, for a clean wound in an otherwise healthy patient, there is no particular evidence that use of pre-incision antibiotics is helpful. So you will have many surgeons who will not ask for pre-incision antibiotics for plastic surgery cases or things where there is a very, very low risk of infection, and of course the antibiotics are not benign in and of themselves. For patients who have clean procedures and have some risk factors additional that make them considered higher risk for infection, antibiotics are often going to be used. And these would be most notably operations lasting for more than 2 hours, several comorbid conditions, or operations involving the abdomen but not necessarily penetrating into an organ. For all other types of wounds, surgical prophylaxis is routine, and prophylaxis is mainly preventing the infections from skin flora, which typically is gram-positives. That's why our first-generation cephalosporins are usually the agent of choice for pre-incision antibiotics. Other cases where you're going to use surgical prophylaxis when infection is catastrophic, such as when you're inserting any sort of foreign material, or whether you're in the brain or in the heart or some organ where infection is going to be really difficult to treat. And then patients who have significant immunocompromise. So as I was starting to say, by far the preferred agent for surgical prophylaxis is cephalosporins. The first generation cephalosporin, cefazolin, is probably one of the most commonly used. In patients who are penicillin allergic, usually the substitution will be clindamycin. And when MRSA is a concern, either a patient who is MRSA positive by nasal carriage, by preoperative testing, or when you're going to be inserting some sort of a prosthetic material like a valve or a penile prosthesis, etc., typically the drug of choice will be vancomycin, which can be administered usually by IV infusion within an hour of incision. The timing of surgical antibiotics, the intention is to have the antibiotic achieve a high enough blood level by the time that the incision is made. So this typically involves a desire to have antibiotics in within 60 minutes of incision. It's probably not ideal to have it within 1 minute of incision. It's probably better to have something like 30 minutes of incision in terms of maximizing the concentration of antibiotic in the blood prior to incision. Kind of the one exception to this is in cesareans, where there's a desire not to expose the infant to antibacterial agents. So typically antibiotics are administered after the umbilical cord is clamped. It's important not to forget that in long procedures, antibiotics need to be redosed. A lot of the drugs are redosed on a Q4-hour basis, so certainly something that you have to get in the habit of reminding yourself about redosing. Because again, the idea is to keep the blood level of antibacterial high during the entire surgery. However, post-operatively, there's no evidence that continuation of antibiotics beyond the intraoperative period is necessary.